My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello, I'm George Fritzma, proprietor of the Fritzma Factor, your interactive hemostasis resource, introducing our presentation, 100 Years of von Willebrand Disease. We welcome Dr. Robert Sidonio, pediatric hematologist and oncologist. Dr. Sidonio is the medical director of the Clinical Research Office at the Aflac Cancer and Blood Disorders Center of Children's Healthcare of Atlanta, and is a professor of pediatrics at Emory University School of Medicine. Dr. Sidonio graduated from the medical school of the University of Alabama at Birmingham, completed his pediatric residency at the University of Louisville, and his clinical and research fellowship at the University of Pittsburgh. Dr. Sidonio's clinical interests are in the management of pediatric hemophilia patients with inhibitors, women and girls with bleeding disorders, and in patients with von Willebrand disease. We will turn to our conversation number 3, advanced assays and von Willebrand disease management. We talked in conversation number 2 in some detail about the phenotypic testing, analyzing subtype 2B, 1C, and the von Willebrand collagen binding. Actually, let's go back to type 2B for a moment and talk about testing for that. That was always, we used to use that ristocetin agglutination test using patients' platelets. What are we doing for 2B now?
Yeah, I mean, we're still doing that. Yeah. So as you know, like in type 2B von Willebrand disease, it's a good start to the testing, right? Mm-hmm. And so this is where you would do, so if you take since it's a gain of function mutation, if you put very low dose ristocetin, you're not going to get platelet agglutination in normal patients, but in a type 2B patient, you'll get agglutination. And so we still use the different concentrations of ristocetin. This is a standard thing in our platelet aggregation studies, so we can catch those patients. And so we'll do that low dose RIPA or low dose ristocetin induced platelet aggregation. And so that's still a really good way of diagnosing a patient outside of doing genetic testing, but it's still a good functional assay, I think, as a way to look to see is there something there. And then certainly you can do genetic testing targeting exon 28 where the mutation variants are.
Yes, that was, we always felt like we were discovering something very exciting when we were doing that particular test. Was very interesting.
We're still using a lot of this technology was created is pretty good, and so there's no reason to stop using it. So
yeah, that's true. Now, moving into genotype analysis, it seems that you've done a fair amount of that. Is genotyping helping to improve management these days?
Yeah, that's a great question. And so there's like two things here, right? So we all know that there's going to be mass genetic testing in the future, right? It's becoming so easy, so inexpensive. The difficult part is identifying all these different genetic variants and the computational part of it. That's where it gets complicated. It's really easy. You can go to different websites. Every time I'm on like Facebook or something, I get ads for you can do whole exome sequencing and find out what's wrong with you, that kind of stuff. And
Yeah.
so, I mean, if you do healthy genes analysis, you can get factor V Leiden tested pretty cheaply. And so I think we're all headed that way. Part of the problem is that a lot of variants are still there. We don't know if they're pathogenic, and they're labeled as a variant of unknown significance. And so I routinely see patients that have had whole exome sequencing or other testing, and they were looking for something else, and then they said, oh, well, we found this genetic variant in the VWF gene. We don't know if it's causative. And then I do testing. 9 times out of 10, the testing is normal. And so that's where it gets a little challenging. If you look at the guidelines, most of the patients don't need genetic testing, right? Particularly the ones I mentioned before, the ones with a very modest reduction, mostly because those deficiencies are probably outside of chromosome 12. There are a lot of clearance receptors that are outside of that. The Irish laboratories have done, O'Donnell and their group have done a lot of work in this. And so that's not on chromosome 12. It's somewhere else. There are other things. And so we know that as the level goes down, the chance of you finding a genetic variant goes up significantly. So above 30%, there's probably limited benefit outside of a study. Below 30%, there probably is a benefit. So I think in type 3, there certainly makes sense. We talked about type 1C, that it makes sense to do it there as well. And then other places it doesn't have to be done, but I think if you identify possible type 2B von Willebrands, it's important because there's also another diagnosis called platelet type von Willebrand disease. Yeah. I think they've been trying to change the name as well, where the defect is on the GP1B. It's not actually on VWF, and the testing looks identical, and you can't identify those patients unless you do that specific testing. I think there's some fancy RIPA mixing studies you can do as well, but for the most part, that's where genetic testing. So outside of that, 1C, type 3, because they're at risk for inhibitors, it makes sense to do it there. And type 2B, it's not very clear if there's a benefit outside of those subtypes. But those subtypes, it keeps getting more and more where we say testing helps. And there's going to be some studies moving forward where they look at this benefit. Did it change the way we approach those patients? Whether they had type 2 versus type 1, are they more likely to treat with factor versus DDAVP or antifibrinolytics? So those kind of studies are being done. Dr. Jill Johnson is looking at whether genetic testing has a benefit with regards to changing how we practice, change how the family feels about it. So I think those are important. But it's also can be done fairly simply because within exon 28, you can diagnose all the type 2M von Willebrands, all the type 2B von Willebrands, and some of the type 2A von Willebrands. And then you could, type 2N has a specific location where the factor VIII is binding as well. And so you can actually diagnose a lot just even targeting exon 28.
Oh, that's interesting. Does the pseudogene get in the way?
Yes. I don't do the genetic testing, but that's something that does require some sophistication when people are doing next-gen sequencing. They have to understand that it's there, and they have to understand that, that they're finding a genetic variant in chromosome 12, not in the pseudogene, which can be a little complicated. So you need a really good coagulation lab that knows what they're doing.
Interesting. Bob and I have a colleague who is diagnosed with von Willebrand disease, but it seems to be outside of all the types and subtypes.
Interesting, yeah.
The colleague and also a member of the family. And have you seen any von Willebrand disease that doesn't fit in the categories?
Yeah, there's a couple of papers out there that are trying to come up with other subtypes like type 2A/M. There's some that don't fit perfectly within those categories. And so, and then there's some people that have multiple different genetic variants. And so if you have 2 variants, it's not going to fit in this nice little system that we created, right? Yeah. And so that's where it gets complicated. There are a lot of patients with type 1/type 2N von Willebrands out there, for sure. they only get identified because they have some low VWF in association with the low factor VIII. And so, yeah, so that certainly can happen. You could have a clearance defect that you're never going to pick up on chromosome 12. It's outside, and you could certainly have low levels based on that. I think the important thing is, when it comes to management, is that we still use the bleeding phenotype. So we use their personal bleeding history and family history. And then we focus on the levels when determining things like treatment. And we try not to get too bogged down into the genetics in making decisions. Because if I have a family that I couldn't find a genetic mutation but clearly has low levels and bleeds a lot, I mean, that should be enough to make some, decisions on how I'm going to approach that patient.
Yeah, it would seem that perhaps in the future, genotyping might begin to predict therapy to some degree, but perhaps not yet.
I mean, the other thing is there was a Spanish group that looked at identifying and we're showing that it might actually be better than some of our functional testing. The only problem with that is that you always need that functional testing to demonstrate there's actually a deficiency. Because we do have patients that have participated in the Zimmerman project that clearly have a pathogenic variant, and now they're 18 or 19, and their levels are completely normal. And so if I didn't do genetic testing on that patient, and that patient is not bleeding, then what am I doing? I mean, I got to be careful about treating. I actually cause harm. And so I think that testing is important. But it's funny is the assays have a certain price, but the genetic testing, it's become a lot cheaper to do. And in many cases, it's probably cheaper than doing the functional assays, but you still need those functional assays. It's really important when you're doing surgery. Genetic testing is not going to help you, right?
Sure. Yeah. Well, let's go on to therapy. And can you treat all von Willebrand disease with DDAVP?
I think in parts of Europe, I think they think that you can. So they always, I'd be curious of the comments from some groups. So it's funny when the variation in practice is quite wild. But like, for example, we've used DDAVP only a few times this year. But if I ask my colleagues in Ireland or Italy, they've probably used it 50, 60 times already this year. And so so you have to do a DDAVP challenge, first of all. So in type 3, there's no benefit because you don't have any VWF. You have to have VWF to stimulate the release, and you don't have any, right? And so patients with levels of 30 to 50%, the majority of those patients will respond. There's some lag in teenagers in their response. Teenage girls, for some reason, have a little bit of a lag in their response, and it might change over time. And when we've looked at it, at the data in the U.S., we don't get as high a number of percentage patients responding. And so as some of the European cohorts, and maybe because we have some more diversity, ethnic diversity. But if you have levels in the 30 to 50%, DDAVP is a reasonable option. The only issue with DDAVP is, as you know, is you have to limit the fluid intake. And that's very difficult if you're pregnant. There's a lot of fluids that are involved in delivering a pregnant woman. And so that's one thing. If you're having surgery like a tonsillectomy, it's very easy for a surgeon or a resident to start some fluids, and now their sodium is 128 in the morning. It can cause a pretty significant drop. And in the elderly and younger children, they're at higher risk for seizures. And so we can see this in young children. They can develop seizures because of that DDAVP and that hyponatremia. And so there are a lot of patients that actually don't like DDAVP for that. It has a lot of side effects. It causes flushing, abdominal pain, nausea, vomiting. And so it has a pretty significant side effect profile. It's a great drug. It was developed in the 1970s, and it was a great option compared to epinephrine. But certainly, I think we're trying to be a little bit more careful on how we treat. And we don't have a good intranasal option here in the United States. Some locations have sub-Q, others have to rely on IV. And so for safety purposes, I don't like using it. And it also makes me feel strange if somebody has a qualitative defect I give DDAVP, so I'm basically pushing out a lot of mutant VWF that doesn't work very well.
Right.
Uh,
Yeah.
but there's probably a factor 8 benefit too. I think that's where we always struggle, is how much of the bleeding is caused by factor 8 and how much of it is caused by VWF. We still don't actually know that today, but somebody will eventually figure this out, maybe.
And can you use DDAVP for type 2B?
Yeah, so you definitely don't want to use it for type 2B. It's interesting, if you read about it, it always says relative contraindication, but you really shouldn't use it. It makes sense. You're pushing out so if you push these out of the endothelium, you're pushing out a gain of function mutation. It's going to grab all the platelets, and you know what's going to happen next. The platelet count's going to tank. And so it's just going to cause a lot of problems. I would never see a reason to use it in any situation. I'd rather use antifibrinolytics if I didn't have anything else in a patient with type 2B von Willebrand. So that is certainly a contraindication. It says relative, but I think it's a strong contraindication.
Are estrogens used a lot?
Yeah, I mean, so typically in a teenage patient that comes in and they have heavy menstrual bleeding, and let's say identify von Willebrand disease as part of the workup, right? Oftentimes, probably the most cost-effective strategy is using hormonal therapy. And so that often includes estrogen therapy, estrogen or combined oral contraceptive. So the old school OCPs, the standard pills.
Yeah.
There are other ways of delivering it as well. It can be delivered in a device that you insert into the vagina. It can be delivered on a patch now, so you can put this patch on and take it off once a week and replace it. And then there are progestin options as well. If it's the dosing is less than 35 micrograms, it probably doesn't stimulate the VWF, but it definitely protects bleeding. If you're giving high dose estrogen, it can stimulate the VWF, but it's temporary. Over time, it just goes back down.
Okay. So I think there are two replacement products now available, Vonvendi and Wilate. And I'm seeing a lot of work with Wilate using it prophylactically. And is that pretty new?
Yeah. So, the history of von Willebrand concentrates is the first one was in the 1980s in Germany, and that was Hume-P. And so it was actually developed before. And I think most centers are probably in the United States are still using Hume-P as part of their formulary.
Right.
And then over time, other plasma-derived concentrates, depending what country you're available. But if you're talking about the United States, Hume-P is available. It's not indicated for prophylaxis. But when you look at Wilate and Vonvendi, they both are. So Wilate's also a VWF concentrate. It's a closer 1-to-1 ratio of ristacine cofactor to factor 8. And then if you look at the ratio of ristacine to factor 8 for a Hume-P, it's a little closer to 2-to-1. And then Vonvendi, it doesn't have any factor 8. It's a strict recombinant VWF option. And that's, finished phase trials about 10 years ago. Took a while to get full approval. But those are two options. So Wilate and Vonvendi. And to be honest, we use Hume-P for prophylaxis in the United States. It's approved for prophylaxis in other countries, but you know how in the United States, oftentimes you have to do trials in the U.S. before you get that label. But before Wilate came along, before Vonvendi came along, if somebody needed prophylaxis, we put them on prophylaxis with Hume-P.
Okay. Yeah. Yeah. We used to call that kind of a plasma-based factor 8 that was intermediately purified.
Yeah. They still categorize some of these as like intermediate purity and such, and so we use some of those. I used a lot of those products for immune tolerance induction and hemophilia as an option as well for treatment. And I remember one of the concentrates actually had a good amount of Adams TS13 in it.
Mm.
and it was often used as a source for those patients that had congenital deficiency because before they developed recombinant ADAMTS13.
Interesting. So, is Von Vendi? I think Von Vendi was only recently approved for prophylaxis. Isn't that so?
Yeah, and so so it was originally only in type 3 von Willebrand patients, and so that's expanded the label over time, showing some data. We've demonstrated, we had a natural history study that was run by American Thrombosis and Hemostasis Network, and we did a natural history study in which we demonstrated that patients that were started on, so it's an observational study, we just wanted to follow the patients and demonstrate that it's safe, it's useful, it leads to low bleeding rates. And we were able to show that very low serious adverse event rate. We didn't see any real issues with it. A number of different subtypes of patients were successfully treated with prophylaxis. Oftentimes, patients are on for either Von Vendi or Willate, they're on it about 2 times a week. And some of the more severe types, like type 3, they may need 3 times a week treatment to get efficacy, or at least to get the annualized bleed rate down to an acceptable level.
Do you just monitor the bleeding rate, or do we use labs to follow the treatment with?
Yeah, that's where it's tough. And so they used to have this group called the Von Willebrand Prophylaxis Network, and myself and James O'Donnell have tried to resurrect this group to try to get refocus on von Willebrands. As you know, there's been a lot of development in hemophilia. We have a lot of great drugs, and we always felt like von Willebrands just didn't get all the attention, right? I mean, hemophilia got all the attention, and so now they're starting to get some of this attention. And so one of the things that we haven't been able to figure out, in hemophilia, we know that if you target certain trough levels, you can achieve certain goals. So for the original goal was 1% trough in hemophilia A. You can mitigate most bleeding, right? You basically make that patient a moderate hemophiliac, right? And obviously that wasn't enough. And then they said, well, if you can get it up to 15%, you could eliminate much of the spontaneous bleeds and the joint bleeds. And if you look at that, once you get above 15%, the joint bleed rate goes down dramatically. And so now that's what they're doing with some of the ultra-long factor VIII and the non-factor therapies. So in von Willebrand disease, I may be foolishly attempting this, but we wanted to look at this. We wanted to look at what are the targets for prophylaxis. And what I learned is it's very complicated. So you have VWF and you have factor VIII, right? And then you have a lot of different subtypes like we talked about. So in severe Hem A, it's super easy. Everybody has the same level, less than 1%. Yeah. And if you do a study in von Willebrand's, almost nobody has the same genetic mutation, right? They have a different variant and they have different starting levels. And so it's very challenging, but we have this Dutch pharmacist who's using we're going to attempt to use some machine learning and AI as well as population kinetics. Can we figure out what the targets are for these patients? So we've actually gone backwards. We took the patients from the Willate trial and we looked at the ones that did really well and the ones that did okay and the ones that did in the middle. And we wanted to look at what's the difference? What targets did we achieve? What area under the curve? So I think it's going to be a couple different models, but our starting, in a couple of months, we're going to offer patients, if we put their characteristics, their levels, their whatever, and we can say, okay, they're having bleeding. We predict if you use this regimen, you can mitigate the bleeding down to an ABR of 2 based on previous studies. So that's what we're trying to do is a population pharmacokinetic study. So we're going to see how good we are at it. Are we good at predicting what doses work for prevention of bleeding? Because that's where it's really challenging. We just don't know what to target. And that obviously is hard if you have a kid with von Willebrand's and I say I want to start them on prophy. They're going to ask, well, what dose is going to work? And I said, well, we can just start with this dose and see what happens. That's not always the best. I mean, unfortunately, that's been what we've done, but we'd like to get a little more precise. So that's what we're working on. And hopefully I'll have a study in a few months looking at that. called population pharmacokinetics of VWD.
Well, there's a lot going on there, it seems.
Yeah, it'll be fun to figure this out. So,
and then one last thing, do you tangle with inhibitors a lot?
yeah, thankfully I haven't seen a lot of VWF inhibitors, and it's mainly because it's thankfully pretty rare. Typically it's seen mostly in the type 3 patients, so those that make very little VWF, and that's typically how antibodies in these diseases happen. Like your body has to make very little of it, so large deletions in hemophilia cause high percentages of neutralizing antibodies. And so you have to have a pretty significant reduction. When we tried to look at inhibitor development in our natural history study, we didn't identify anybody except for the one patient, the 2 patients on the study that already were identified. But when those patients develop an inhibitor, it's extremely difficult to manage. You can't use any concentrates. We're using like activated prothrombin concentrates to manage those patients, and they're also using emicizumab, a non-factor therapy as well, because sometimes the antibodies are directed against the factor 8 and VWF, and sometimes only the VWF. And so it can be very challenging. Thankfully, they're extremely rare, but one of the problems is we don't really have, there's very few places that can do inhibitor testing. It's usually a ristocetin-based assay. So CDC used to do this when I was working with Connie Miller. She was going to get this assay up and running, and, we know what happened there. It wasn't going to happen. So,
right. Is there anything you would like to add?
Yeah, I think the great thing is obviously we have a lot of great concentrates for those that are bleeding that need to be on demand, and then the less commonly on prophylaxis. And hopefully people are focusing on identifying those patients, documenting their bleeding, and then offering prophylactic, therapy with one of the concentrates that we have available in the United States. But the really exciting thing is there's a lot of new therapies that are being investigated in von Willebrand disease, some targeting the coagulation pathway, maybe through a rebalancing type of agent. And some of them are antibodies that reduce the clearance. And then some of them are targeting plasminogen and making it quite deficient, so it mimics like a megadose of tranexamic acid. Yeah. And so there's lots of strategies that are being investigated. So we're really happy because right now this is probably the most clinical investigation that's happened for von Willebrand's in a long time. So we're excited for the community.
I tell people so much has been done for hemophilia that people are now turning their attention to von Willebrand disease.
Yes, thankfully. Yeah, thankfully they're getting us some of that attention. So,
well, we just have to get the word out to people. What is von Willebrand disease? Because nobody knows that. Yeah,
I know that it needs a better PR campaign because it just doesn't have maybe. I mean, the name is not going to change because it's based on VWF, von Willebrand factor, and even though they are removing some people's names from things, it's already called VWF, and so it's not going to get changed. So we just need a good PR campaign to get the word out. So,
yeah. Well, this concludes our third and final conversation. Dr. Sidonio, thank you for your expertise. We encourage participant questions and comments, and there's a link on the Biomedica Diagnostics website for you to download the video and the transcript of all 3 talks and to forward your questions or comments. Thanks again to Biomedica Diagnostics for sponsoring Coag Conversations, and thank you for your participation.